I'll now welcome the next speaker, Dr. Maureen Lechfeld. She is the Dean of the Graduate School of Public Health at the University of Pittsburgh. She's the Jonas Salk Professor in Population Health. She's a professor in Environmental and Occupational Health. She is a member of the National Academy of Medicine, and she is a professor at the University of Pittsburgh. And her talk is going to be on the triple risk burden, environmental exposures, pregnancy, and disparities.
Good afternoon. I'm really pleased to be here. Just as the previous speaker indicated, to meet colleagues for the first time. And so I'll be taking you from the left side of the research continuum to the right side of it, talking about people. Just want to make sure I'm doing things the right way in terms of advancing the slides. Got it. And so my objectives this afternoon are to define environmental exposures and the exposure pathway, to discuss how chemical and particularly non-chemical stressors affect women's health and link to that metabolism, to examine really the complex interactions among environmental exposures, metabolism, and adverse birth outcomes to a bit, and then end with providing proposing actions in research, policy, and practice. And so I'll take you a little bit to policy here. The Toxic Substances and Control Act is an inventory nationally of all the chemicals that appear in our world as we live, as we breathe, as we eat, as we drink, and wherever we go. And so I'd like you to focus on that number 86,000. That's how many substances of all kinds and all classes really enter into our world, and particularly also look at the chemicals that are not included that we encounter every day, such as pesticides and food additives, and yes, cosmetics. And it was, I don't know how to feel about the oldest woman in the world holding a cigarette, but it is there. But then I'd like you to focus on that other number in yellow, and that is across our agencies, and I was almost 20 years a member of the Center for Disease Control and Prevention, particularly the Agency for Toxic Substances and Disease Registry. And you could see that of the 86,000, we're able to develop toxicological profiles examining the impact of those chemicals of only 200. And so the moral of the story here is that there are thousands of chemicals around us impacting everything, including our metabolism, that we don't know much about. And so as I often teach, I want to make sure that you know, and as I tell my students, I should be able to wake you up at 2 in the morning, and you have to tell me this. You have to be able to recite that in order to have a completed exposure pathway, there must be a source. The chemicals have to come from somewhere. There must be a way, the Lyfts and the Ubers of the world, there must be a way that that chemical comes to us. Those are the environmental media. And then there must be a place, a point where we're exposed. That's the exposure point. And ultimately, there must be a way, there must be ways in how that chemical then out of the environment comes into our body, and in this case particularly into the body of a pregnant woman. And then ultimately there need to be people who are vulnerable, among those specifically pregnant women. And so that is the completed exposure pathway. Just as you saw all the measurements that are happening at the basic science level, we too are looking at the clinical level on the types of exposures, and in this case using biomarker testing. I particularly want to point out to the markers of susceptibility. Now, it's easy enough to look at markers of exposure and markers of effects. It's much more difficult, but critically important for us to look at and examine markers of susceptibility, because that's where the answers will be. And so from a metabolomics and metabolistic standpoint, there are a number of sources of exposure, in this case, endocrine disruptor chemicals. And the ones that we are very concerned about are some of the ones in yellow, where we don't know enough about. Similarly, if you look at the susceptibility, as I mentioned before, of pregnancy and the exposures that occur during pregnancy, on the group of chemicals, if you see the table, the third from the top, and those are what we call the forever chemicals, the chemicals that are in everybody's kitchen, the chemicals that are part of our plastics, the chemicals that are in our drinking water, including in Pittsburgh, and in Western Pennsylvania. So the chemicals that we don't even know, many people don't even know that we're ingesting and inhaling as we speak. Early life exposure, and in this case from pregnancy, fetus into early life, have critically important impacts on what happens later in life. We saw it with obesity, we saw it with aging. Those exposures and the influence of that happen very early in life. What also happens very early in life are the influencing factors of health disparities and health inequities. So beyond the physical exposures, we are worried, and we know, and increasingly we're seeing the real impact around housing, around access to health care, around pollution, environmental pollution right where we live, around poverty, and around not having culturally competent providers. And so we look at exposure in addition to the more or biological aspects. We look at exposure from a public health perspective, and it was great to hear at the end of the last session that we are all worried that public health is not sexy, because on a good day in public health, actually nothing happens, right? We're all healthy. I always tell a story about a mayor who closed a week before a major illness, foodborne illness, the local health department, because why do we need one? And then the foodborne illness happened, several people died, and he was screaming and saying, well, who should take care of this? And so somebody on his staff told him, actually the health department, the people you just sent home last week, they take care of those things. And so from a public health perspective, there are some aspects, and Dr. Finkel mentioned those, of genetic consequences, but they're very, very minor if you look at the bigger picture. Chemical stressors, as I shared with you before, but particularly if you look on the lower left button, was what's going on in the community. And we typically call those community assets or lack thereof. Then the connection between an individual's exposure and a community's exposure and the environment, and ultimately you could see that the moderating factors play a key role, and I'll mention that in more detail when we look at population health exposures. So I'll share with you two case studies. The first one is the largest oil spill that happened in 2010. I worked and lived in New Orleans back then. We had an unprecedented, we had deaths, of course, in the people who were on the rig, sadly, workers on the rig. We had an unprecedented use of a chemical upon a group of chemicals that was supposed to break the chemicals into smaller, teeny tiny chemical chains. And I'll ask you, when you think about the word dispersants in English, of course, doesn't mean elimination. And so we added chemicals up on top of spill. We were funded by NIHS to answer 3 simple questions that communities have. I do community-based participatory research. And they had just 3 simple questions. Is the seafood safe to eat? Is the air safe to breathe? And what will happen to our babies, the women who were pregnant at that time? And so we used a number of strategies, including working with community health workers and with the fisher folk that you see on the right picture there, where we went shrimping with them. And we analyzed not necessarily what they sold, but actually what they ate. But before I go that, I want to point out that of all the concerns that were there, the major concern was around the non-chemical stressor, was around finance and the lack thereof. And so here is the value of using local data and working with communities where they actually are, rather than this risk assessment that looks at the 90-kilo white male to determine what the actual risks are. And so this was a meeting with major federal agencies, and the federal officer said, well, in general, in our country, we eat 4 shrimp a day. Upon which a Vietnamese fisherman stood up and said, you may eat 4 shrimp a day. We eat 4 pounds a day on our plates, on our po' boys. Also, Vietnamese communities are not 90 kilos. They're about 68 kilo. And using these very community-tailored data, we were still able to show that it was acceptable to eat the shrimp. This was critically important because 2 things were happening. Pregnant women were stopping eating fish, and healthy for them, and switching to beef. Secondly, if they really wanted to continue to eat seafood, they ate imported seafood, and the imported seafood was more contaminated than the locally caught seafood. And so we had a double whammy of negative impact. And so I'll take you now to the country I was born in. If you're wondering where my accent is coming from, it's half Dutch. It's Suriname in the Caribbean. And there, we are also funded by Fogarty and by NIHS to follow a diet of 1,200 women and their babies, particularly focusing on exposures to metals and to pesticides. To the left, you see 2 pictures. The first one is a very primitive device, and it's called a sluice box. And in that device, mercury is added to the mud to release the lead, to release the gold. This is gold mining, so a simple chemical reaction. But what is not so simple is what's happening to the fish, the only source of protein that pregnant women eat. And this happens to be a piranha, if you recognize that. And so a number of questionnaires were implemented, a number of data analyses are currently still going on. But so for today, I'm able to share just a little bit of the data with you. Remember that completed exposure pathway, and we wanted to see what's in the fish from what's coming out of the environment. So if you look at the total mercury of fish, that first one, you see that the freshwater fish, and among them the Serrasalmus rhombeus, that's the piranha in a fancy name, those fish species show the highest levels of mercury. And then below, and this is an interesting piece that we're trying to figure out more, those are also the same fish that have the highest level of a potentially protective metal, and that's selenium. The women who lived there preferred those fish that had the highest level of mercury and not the other fish, such as more of the marine fish. So these are some of the characteristics of our cohort. As you can see, they're younger. There is a tremendous amount of ethnic diversity. They are lower educated. They are lower income. There's obesity. And there are differences in where people live with respect to exposure, and I'll come back to that. So I'd like you to follow the yellow bar with me. So these are the 3 major areas where our study is occurring. That yellow bar shows the interior. This is the Amazon rainforest. We go deep into the rainforest as we do our research, and in fact, next summer, I'll be taking Pittsburgh students with me for the first time. And so if you see the dotted line that's going across horizontally, that's where we in the US are concerned about the level of mercury. And you could see how many magnitudes higher those levels are in those pregnant women. In addition, and that was not what we were looking for initially, you see the level of lead. Another chemical, both chemicals that affect neurodevelopment in kids, you see that level also above, far above, what we in the US would be concerned about. But then you also see the selenium levels very high as a potential protective measure, and the other chemicals on the bottom are those that we are concerned about with respect to pesticides. And so when we did a predictive model, we were able to show that the higher the blood lead level, the lower the birth weight, and that was statistically significant. Furthermore, we were able to show that the higher the maternal age at intake, the lower the birth weight. We know that, but I want to come back to that last line there where we looked at the differences in where people lived. If you look at the differences in where people live, clearly the people who lived in the Amazon rainforest had the highest mean of blood lead levels. And when we looked closer and we compared them with all the other locations, you see that all of those levels were statistically significant. So there is higher contamination in women, in pregnant women in the interior, higher than any other place of where we have our study. And so the little bit of metabolism, of course, that many of you know about is the competition between the iron molecule and lead on heme, and therefore leading into a decrease in hemoglobin levels. I won't take you to the nitty-gritty of toxicology. But what I do want to show you is the anemia in these pregnant women. This is a subset of the 1,200, and you could see that almost 66% of these women are anemic. So elevated mercury levels, elevated lead levels, anemia. When we go on from and look at cumulative risk between the chemical and the non-chemical stresses, here are some data, again, of a subset on perceived stress. And you could see, using the Cohen perceived stress scale, where we are. And this is a significant percentage of women are also stressed, have high perceived stress. The same goes for probable depression during pregnancy using the EPDS. Again, you see the elevated levels here. I do, every year that I go, I'm obligated to, and I do willingly, these special risk communication sessions. It challenges me to get up to speed in Dutch again, and in all the local languages, but it is important for people to be able to intervene and work with governments to implement actions on the front line. And so if we look at where we need to go further in terms of research, policy, and practice, there must be more emphasis placed on conducting longitudinal environmental epi-studies, particularly focus on metabolic markers and metabolomics for all of our 1,000 women. We will be doing metabolomics actually funded by NIH and particularly NIEHS. Taking into account the multiple ethnicities and what people eat, the culturally dietary traditions, and the potential, as I mentioned before, protective factors of selenium. We will be focusing more on the environmental sources of lead, and in this case, it's not air pollution, it's cookware. It's what people use to cook with that we've seen so far, but there is more research going on there. And working very closely with the community on tailored interventions, as I mentioned before. From a policy perspective, it's very important that although we have many policies here and we have a challenge with enforcing those policies, in many lower and middle income countries, those policies don't even exist. Suriname just signed on to the Minamata Convention, but I'm not sure how far they are in terms of really implementing that. And lastly, from a practice perspective, there is nothing that I could do without community health workers, and these are locally, we train those locally, those partners locally, and actually provided them with cell phones. And so I want to leave you with where this is all headed. While we focus, and this conference is focused on women's health is inextricably linked to the health of our kids and the next generation. So this gives you a sense of how culturally diverse Suriname is. And leave you with acknowledging my collaborators. Thank you.